Hello students, I am Kuberan as an assistant professor in Renal Science and Dialysis Technology, School of Allied Science, VMRF-DU, Salem. Today the topic is about CRRT, Continuous Renal Replacement Therapy. CRRT is a topic about for the patients who are doing the treatment of dialysis is one of the modalities. So next we take the classes of. So objective of the classes is introductions, principles, modalities, vascular access, equipment, anticoagulations, complications and the conclusions. So CRRT. CRRT is commonly used to provide renal support for critically ill patients with acute kidney injury, particularly patients who are all hemodynamically unstable. So the variety of the technique that differ in their mode of solid clearance may be used, including convective solid clearance and diffusive solid clearance. The CRRT is a slow and continuous extracorporeal blood purification therapy. CRRT mimics the functions of the kidney in regulating water, electrolytes and toxic products by continuous slow removal of solute and fluids. So indications. Renal indications may be persistent AKI, uremia, metabolic acidosis, anuria, hyperkalemia, increased levels of phosphate, hyponatremia, decreased levels of sodium, hyperphosphatemia, increased levels of phosphorus. So the non-renal indications are systematic inflammatory response, sepsis, congestive cardiac failure, multi-organ failure, crush injury, liver failure, lactic acidosis, increased levels of acidosis, acute respiratory distress syndrome, tumor lysis syndrome, inborn errors of metabolism. So the principles of the CRRT is ultrafiltration. Ultrafiltration, the movement of solute from the region of higher solute concentration to the region of lower solute concentration through osmotic pressure gradient or hydrostatic pressure gradient. So diffusion. So diffusion is the principle of movement of solute from the region of higher solute concentration to the region of lower solute concentration through a semipermeable membrane. Convection. Convection is the principles of solute along with a solvent drag. Modalities of the CRRT. So modalities are commonly used: CVH, continuous veno-venous hemofiltration; CVVHD, continuous veno-venous hemodialysis; CVVHDF, continuous veno-venous hemodialysis filtrations; SCUF, slow continuous ultrafiltration. So we see the one by one of the topics of modalities. CVVH, continuous veno-venous hemofiltration, uses hydrostatic pressures to induce the filtration of plasma water across the hemofilter. Solutes are removed entirely by the convections. So dialysis fluid is not used, only the replacement fluids used. The replacement fluids are used to replace the body fluids of the patients. CVVHD, continuous veno-venous hemodialysis, is a primarily removed solute by diffusion. Dialysis fluids used. The dialysis fluids is run counter current to the direction of blood through a direction of dialysate flow at the rate of 1 to 2 liters per hour. The ultrafiltration rate is generally only 2 to 8 ml per minute. The dialysate flow is about 20 to 25 ml per kg per hour. In CVVHDF, ultrafiltration is limited to the rate at which the net fluid removal is desired and no intravenous fluid replacement is required. CVVHDF, continuous veno-venous hemodiafiltrations that combines both diffusion and convection principles. CVVHD requires infusion of both replacement fluids and dialysis fluid. Similar to CVVH, the ultrafiltration volume is variable and the replacement fluids must be given to maintain evolemia. The amount of replacement fluids that is given is determined by the net volume removal that is desired. SCUF, slow continuous ultrafiltration, is used to treat isolated fluid overload of the patients. SCUF is not used in the patients who are all uremic or hyperkalemia because solute removal is minimal. SCUF can be safely removed up to 8 liters of fluids per day. Neither replacement fluids nor dialysis is used. So the convection solute loss is limited since the ultrafiltration rate is slow compared with CVVH, slow continuous veno-venous hemofiltration. There is no diffuse solute loss since the dialysis fluids is not used. The blood flow is generally 100 to 200 ml per minute and the ultrafiltration rate is at 2 to 8 ml per minute. So the basic components in the CRRT is the solution bag, the hemofilter and the tubings, the CRRT system, the blood warmer, the vascular access and the anticoagulation systems. So the vascular access. CRRT requires a reliable vascular access capable of blood flow at the rate at least 200 to 250 ml per minute. The standard is a WM tunneled or a non-tunneled dialysis catheters. Among end-stage kidney disease patients who have arteriovenous fistula or arteriovenous graft for the maintenance hemodialysis, the fistula or a graft should not be used for the CRRT unless no other access is possible because the risk of the dislodging the needle and the causing bleeding or injury to the AVF or AVG. The preferred catheter's access is the right interjugular vein all through the femoral vein may be used if necessary. The subclavian vein should be avoided if possible, as subclavian catheters have been associated with stenosis of the subclavian vessels, which may be prevent placement of future AVF or AVGs. CRRT dose. CRRT dose is defined by effluent flow rate. The effluent is the waste fluid that comes out of the outflow port of the dialysate ultrafiltrate compartment of the hemofilter. The large clinical trial have shown a benefit of higher CRRT dose, the greater than 35 to 40 ml per kg per hour. The compared with standard CRRT dose, the 20 to 25 ml per kg per hour is preferable when they applied over the entire duration of the patient CRRT dose. In addition, higher doses of CRRT, particularly if prolonged, may lead to protein malnutrition, serve deficiency of many vitamins and micronutrients, and inadequate antimicrobial drugs levels. The filtration fractions. It plays a major role in the CRRT. The filtration fraction is the proportion of the plasma water entering the dialyser and that is moved by ultrafiltration across the dialyser membrane. It is the fraction of water that is removed from the blood. It should be maintained less than 20%. The higher fractions are associated with increased circuit clotting, presumably from hemoconcentration and blood proteins membranes, interaction within the hemofilters. The filtration fraction is arithmetically defined as the filtration is equal to ultrafiltration flow rate divided by plasma water flow rate. The ultrafiltration flow rate is at which the plasma water is transferred across the membrane driven by a pressure gradient between the blood and the dialysate ultrafiltrate component. The plasma water flow is the rate at which the plasma water is delivered to the dialyser or a hemofilter. Anticoagulation. It plays a major role, but it may be differ to the patient and the patients. CRRT may require anticoagulation to prevent clotting of the extracorporeal circuit, although CRRT without anticoagulation is often attempted. The most commonly used options for CRRT anticoagulations include regional citrate (RCA) and unfractured heparin. RCA decreases the rate of clotting and may be used in all the CRRT modalities. The compared with systemic heparin, RCAs reduce the risk of bleeding. During regional citrate, sodium citrate is infused into the flow rate, the limb of the extracorporeal circuit, chelating the calcium and the inhibiting of the clotting, the decreased levels of calcium while we are using the regional citrates. A systemic calcium infusion is required to the replacement of the calcium that is lost in the effluent in order to maintain a normal ionized serum calcium concentration. Complications of the CRRT that related to catheter and non-catheter related complications or extracorporeal related complications. The catheter related complications are hemorrhage, infection, venous thrombosis, venous stenosis, thrombotic arteriovenous fistula, pneumothorax, hemothorax, air embolism, visceral injury. So the non-extracorporeal circuit relation complications are allergic reactions to the hemodialysis, hemofilter or the tubings, the circuit thrombosis, hemolysis, air embolism, hypothermia, hypotension, the decreased levels of BP are less than the hypotensions, electrolyte disturbance, hypophosphatemia, hypokalemia, hypocalcemia, hypomagnesia, the decreased levels of electrolytes compositions. Conclusions of the topic. CRRT became a mainstay in the management of AKI in the critically ill patients, the patient who do not have a objective indication for the emerging initiations of renal support. The optimal timing of RRT remain controversial. Thank you students for watching the class.